Hello, welcome everyone. My name is Salah Al-Hamamsi. I'm an assistant professor in Brown University. Today, I would like to introduce my guest, Dr. Taro Minami, the director of Point of Care Ultrasound in Care New England. We are going to discuss the use of point of care ultrasound in the management of coronavirus patients. I'll start by talking about the background of Dr. Minami. He has a very interesting background. He is a graduate of Kyoto University, Japan. After graduation, he did internal medicine residency in Japan and then did a fellowship in epidemiology. He moved to the United States in 2003 because he has a passion for medical education in the United States. He did internal medicine residency in New York again in the United States and then moved to Brown University, did a chief medicine year, and then he did fellowship in pulmonary, critical care medicine, and sleep medicine. He is an expert on the use of point of care ultrasound. He is currently an associate professor in Brown University, adjunct professor in Kyoto University, fellow of the American College of Physicians, fellow of the American College of Chest Physicians, and the director of point of care ultrasound in Care New England. He teaches hospitalists, residents, and fellows on the use of point of care ultrasound. Welcome, Dr. Minami.
Oh, thank you. Thank you, Salah. Thank you for a very nice introduction. It's a great honor and a pleasure to be here. Thank you for having me today. And I'm very excited to talk to you and everyone about the use of point of care ultrasound, especially in the era of the COVID-19. Yes.
Yes. So start by telling us what is point of care ultrasound.
Sure. So the point of care ultrasound is really a new concept, probably around 10 to 20 years around here. So by definition, so when you take a look at the article by New England Journal of Medicine published in 2011, it's very simple. Point of care ultrasound is the ultrasound provided by the provider at the bedside, and the results applied to the patients in front of you at the bedside. So the ultrasound by you for the patients and carried out and interpreted by you provider. So that's a point of care ultrasound. So a little more extended notion is that the point of care ultrasound is the ultrasound carried out by the provider at the bedside, and you obtain the images yourself at the bedside and utilize that information for the patients in front of you. So it's in a way is an extension of the physical examinations. And in fact, when you take a look at the guidelines by the American Society of Echocardiography about the focused cardiac ultrasound, which is part of the point of care ultrasound, is they clearly mention that this focused cardiac ultrasound is sort of an extension of the physical examination. So like a stethoscope, and we could say in 21st century, the point of care ultrasound is sort of the extension, or more so 21st century, of the stethoscope. I hope I made it clear enough to you and the audience about the concept of the point of care ultrasound. And in a way
that we can use as physicians, as hospitalists and critical care physicians, without needing the radiologist to read the report. Like we can use it on site and right away as we are treating the patient.
Exactly. So that's exactly the essence of the point of care ultrasound. So in a way, if you order the ultrasound, abdominal ultrasound, for example, and the next day or a few days later, radiology tech shows up, do the examination, bring the machine back to the radiology suite, and the images are read by the radiologist. They write a report and send the report back to you, and you read the reports. So that's a sort of the conventional, ultrasound. That we do not call point of care ultrasound, and we do not call it because you are not the one who did the ultrasound examination. You are not the one who read the images. You didn't analyze the images yourself. Well, you read the reports and you utilize the information, but that's it. So in this case, missing part is that you didn't do the examination yourself. You didn't analyze the images yourself. So these parts are missing. So we
So,
don't call it point of care ultrasound. It's a conventional ultrasound. Yes.
so how about in COVID-19? What's your experience using the point of care ultrasound in managing COVID-19 patients?
Yeah, that's a great question. So it's quite helpful, and to make it clear. Oh, and also, by the way, I have to make a very clear statement about my own COI, conflict of interest, because I'm a consultant of the Fujifilm, which is the ultrasound maker, Fujifilm Sonosite, which is making ultrasound, and I'm a consultant. So the audience has to be aware of my conflict of interest. So back to your questions. Um, Back to your questions, that how you utilize the point of care ultrasound for patients with COVID-19. Well, first of all, it's quite helpful because we learn a great deal. And let me start from the lung ultrasound. And the lung ultrasound is really a new concept, even though the founder, Dr. Lichtenstein, Daniel Lichtenstein, who studied the lung ultrasound more than way more than 20 years, 20, 30 years ago. So it has its own history, but it's people recognize the utility of lung ultrasound more and more for the past 10 years or so. And it's quite helpful because when you scan the patients with suspected or confirmed COVID-19, there are certain specific patterns of the lung ultrasound. So we could utilize that information to predict for example, and we tried to see if we could utilize that information for prognosis, but also there are certain patterns that we could recognize unique to the COVID-19, or more, not necessarily unique to the COVID-19 per se, or more so unique to the viral pneumonia maybe, but there are certain patterns that we could recognize, okay, this might be more consistent with COVID-19 rather than CHF, for example. So yes, it's quite helpful. And speaking of heart failure, it's not only lung ultrasound. Point of care ultrasound is from top to bottom. So I do, for example, echocardiography, or more specifically, focused cardiac ultrasound.
Mm-hmm.
So some of the images, CAT scan, chest X-ray, might be similar for the patient with heart failure versus COVID-19. But let's say if you do see, echocardiography and the LV systolic function is quite down, and then we have bilateral diffuse B lines, our clinical concern is more so, even though we still have to suspect COVID-19, but the clinical suspicion is more so to the heart failure, acute decompensated heart failure, or acute cardiogenic pulmonary edema, rather than the COVID-19 pneumonia. So, yeah, so bottom line, it's quite helpful, and the more so, and nowadays, because it's not that easy for these people to go to the CAT scan because of the cleaning issues, because of the infections control, the bedside ultrasound or point of care ultrasound is more so useful because we simply grab the machine, go to the bedside and do the examinations. We still need to clean the machine just like we need to clean a CAT scan, yes, but it's extremely helpful because the point of care ultrasound would give us the information right there at the bedside almost immediately. So and also to make it clear what I'm doing in a hospital, because I'm a pulmonary critical care physician, so I work mainly in the intensive care unit, not on the medicine floor, but more so in the ICU setting. So I tend to see much sicker patients, I presume. So what my experience might be pretty unique one. So to be clear, I do not see those, less sicker patients on the medicine floor. But as far as I'm concerned, working in the ICU, it's extremely helpful.
Mm-hmm. And you mentioned a couple of interesting points. So regarding CAT scan, CAT scan is very sensitive to
Yes,
COVID-19. But the
yes.
problem we had in the hospital during the surge, we were very busy and we didn't want to send a lot of patients to get a CT scan of the chest unless it was going to change the management because of all the problems with transporting the patient and
Yes.
with having to decontaminate the CAT scanner. So we were depending more on the portable chest X-ray as our main imaging modality. Would you say that the point of care ultrasound is more sensitive than the portable chest X-ray, or the portable chest X-ray is a more sensitive test?
Yeah, so point of care ultrasound is more sensitive in many areas, and there are lots of articles already being published for the past 10, 20 years. So yes, for example, the early pulmonary edema may shows up, and we could detect by detecting what we call the B lines. It's a vertical white lines arising from the pleura, and that's quite a sensitive signs, even more so compared to the chest radiography. And the lung ultrasound could be as sensitive or even more so sensitive, even compared to the CT scan in some field. And you're right, because you brought up the important points. CAT scan is great. Like in China, I believe they did the CAT scan for many COVID patients. But here in the US, we have some limitation. That's transportation issues. Again, it's infection control is quite important, obviously. And also, we have to clean the machines every time we use the CAT scan. So sending the patient to the CAT scan, of course, we do all the time, but may not be as easy as we may think. So, and a CAT scan is reported to be quite sensitive to detect COVID-19, and that's why even at the earlier phase that we had some discussion, even CAT scan could be a screening tool. And the American College of Radiology says, well, we got to be really careful about that notion. And the reason that we just discussed, because of the issues of transportation, infectious control, cleaning, protection of the staff, etc. So we got to be careful about the notion of the CAT scan as a screening tool to detect the COVID-19. And again, back to your questions, can ultrasound be more sensitive to chest radiography in terms of certain area? The answer is yes.
So tell us some of the findings that you find in COVID-19 patients when you use the point of care ultrasound in the ICU.
Absolutely, and let me start from the lung ultrasound, because that's the main field, and I think it's quite important when we talk about COVID-19 and a point of care ultrasound, because as we know, one of the major manifestation is a respiratory system. Respiratory failure is being one of the major manifestations. Even though we believe it's a more systemic pathology involving the vessels, everything that's. So COVID-19, we should not limit to the respiratory system, but the respiratory system is quite important. And the lung ultrasound is a great tool to assess COVID-19 patients. And then first, we do assess the sliding of the pleura, which we can observe by the horizontal movement of the visceral pleura and the parietal pleura sliding to each other. And we call it sliding lung signs. And it's particularly helpful because we see this, we could rule out the pneumothorax at the point of the examination. We gotta be careful because we have to scan all the points. But at least we could say, as long as we do see sliding lungs, we do not have to worry too much about the pneumothorax. And that's based upon the many articles, but particularly Dr. Daniel Lichtenstein published the famous article in 1995 in Chest Journal. And he basically scanned everyone by lung ultrasound, did the CAT scan and compare. And you do see lung sliding, almost 100% of people have no pneumothorax. If you don't see lung sliding, we still have to be careful how to analyze the data. But again, the sliding lungs is important. But when you take a look at the pleura, for the COVID patients, usually the pleura is very smooth and there is no irregularity when you take a look at the pleura. But those people with a COVID-19, that the pleura is quite irregular, which you can observe by lung ultrasound. And even more so, we do see a tiny consolidation beneath the pleura, which we call subpleural consolidation. So those are the very characteristics findings of the COVID-19, not specific, but when you see it, at least we could argue more so for the inflammatory infectious process as compared to the non-inflammatory process such as acute cardiogenic pulmonary edema. So those are the one findings. The other findings, when the lungs is getting wet, we do see vertical lines arising from the pleura we call B line, ABC, B lines. And we see more and more B lines, but not only that, we do see the B lines join together, and it's a it looks like a one B line, but it looks like a thick, dense B line we call coalescent B lines. So this is also quite an important findings. And if the lung is getting even more wet by the COVID-19, and as you may recall that the COVID lungs pathology by the CAT scan is, well, I shouldn't say dominant, but often seen peripherally. So the lung ultrasound is quite useful because the lung ultrasound is good on looking at the peripheral region of the lung. So the more the lung becomes wet, the more B lines we could observe. And for the severe cases, B lines are so much to the point the entire intercostal space looks white. We call it below variant, which we described briefly in a paper we published 3-4 weeks ago in a journal. And Dr. Kosuke Asukawa at Georgetown and I did the brief research and reported in the journal. So those who are more interested in that, you could read our paper to get to the details. But so again, the thick irregular pleura, subpleural consolidations, multiple B lines, but particularly the fused B line, we call it coalescent B lines. And if B lines are getting more and more, we see the white lung, the entire lung fills of white, and we call it below variant. It's a very peculiar term, but there are a couple of very unique findings for patients in a COVID-19, and which is quite helpful for us for the everyday practice, for the diagnostic, and also to assess some of the prognostic factors. Yes.
Yeah, thank you so much, Dr. Minami. And we're going to have more meetings and talk more about the use of point-of-care ultrasound in COVID-19 and in other situations in medicine, in the ICU and on the medical floor. And also, we will be very interested to see some pictures and videos of the ultrasounds that you have made and the paper that you have published in the future. So in future videos, we're going to go through that.
Yes, absolutely. And I'm hoping that we could share some of the images. And in fact, you could go to our, I don't know if you could put some information to our paper, which was just published, that there are certain characteristic pictures. And we also posted the movies on the website of the journal. So you could take a look at, to get some concept of the COVID-19 and the lung ultrasound findings. Yes.
Yeah. Thank you so much, Dr. Minami.
Oh, my pleasure. Well, thank you so much for having me, and it's a pleasure and an honor to be here. So again, I appreciate your having me today.
Thank you.
Thank you.